Okay, well, the two sort of main non-arthroplasty surgeries for the hip that I'm going to talk about is hip arthroscopy, surgical dislocations of the hip, and then a little bit about cord decompression for AVN. So surgical dislocation of the hip is a very useful technique popularized or actually described by Reinhold Gantz in the early 2000s and is the precursor to sort of modern day hip arthroscopy. It involves the ability to safely dislocate the adult hip without disrupting the blood supply to the femoral head and risking AVN. He did a lot of work defining the circumflex arteries, and particularly the posterior ascending branch of the medial circumflex artery of the femoral head, which supplies the majority of blood to the femoral head. It's very nicely described, the technique, in various articles. This is probably the best one from the JBJS in 2001. These are just a couple of drawings taken from that article about how you go about doing the surgery. So the approach is a lateral split through tensor fascial arter to expose the lateral aspect of the hip, pretty much like we would do for any hip surgery or acetabular surgery. And then taking about a 10 to 15 millimeter sliver through the greater trochanter underneath the attachment of gluteus medius from a posterior aspect, and then flipping that fragment of bone anteriorly to expose the anterior capsule. Then this anterior capsulotomy is designed to try and allow good closure afterwards and preserve the posterior ascending branches, blood vessels, which run along the femoral neck, but also in the capsule. So the Z shape of the capsulotomy is described with the rim, the sort of starting limb of the Z, beginning on the acetabular rim posteriorly and then running along from, I guess looking at that, it's about 10 o'clock to 2 o'clock, and then a longitudinal incision through the capsule and then down along the edge of the anterior femur. So you can flap those two sort of V-shaped flaps of capsule, one posteriorly, one anteriorly, and then have good perfect access to the femoral head and dislocate the hip. Obviously, the ligamentum teres is still attached, and sometimes this needs to be cut, but usually the leverage and the force that you can get from anteriorly dislocating the hip, with the leg, holding the leg and twisting on the femur, is strong enough to just tear the ligamentum teres. The blood supply from ligamentum teres is quite important in the pediatric patient, but there's only a very small percentage of blood supply going to the femoral head through ligamentum teres in an adult. Preserve the labrum. Obviously, in this incision, you just got to be careful to preserve the labrum. It's quite easy to see the labrum. If you just cut through the capsule carefully, then you see the labrum because there's quite a big capsular labral recess. So obviously, depending where you make those incisions, even if you cut right over the labrum, if you're just careful with the incision, you can incise the capsule and then see the labrum underneath and preserve that. Some people, there were a few surgeons who tried using this approach for resurfacing arthroplasties. it probably, yeah, I'm pretty sure it's not necessary. The majority of resurfacings are done from a posterior approach, and there was a concern that the disruption of the blood supply to the femoral head would result in poor fixation of the femoral resurfacing component, because one of the relative contraindications to resurfacing is AVN with quite a lot of bone loss, but it hasn't really proved to be much of a real practical issue. So there were some surgeons in the early days of resurfacings that would do hip resurfacings through this trochanteric flip osteotomy anterior dislocation approach, try and preserve this posterior blood supply. We've done probably, I don't know, maybe 5 or 10 of these procedures. They're mostly useful for, in this case, you can see a large acetabular osteophyte being removed, and then the labrum being sutured back into the acetabular rim with bone anchors. So this is kind of work that is done a lot arthroscopically nowadays, but it is useful. You just get a really wide view of all of the structures with an open procedure, but it's obviously quite a big thing to do. So it really is reserved for quite severe cases that are going to be very difficult to do arthroscopically, I think. But a very useful approach to treat femoral head fractures. And I'm just trying to think, Sitombo uses this quite a bit for some femoral head and acetabular combined fractures. Useful. This is just showing the femoral cam debridement, and the Gans actually designed these semicircular perspex guides that you could assess the roundness of the femoral head, and then whenever the femoral head becomes out of round, particularly on the sort of anterior head neck junction region, which is what is a cam, what defines a cam lesion, and you could mark it with an osteotome, and we use this little plastic device to mark exactly where it comes out of the round shape, and then osteotome that whole cam lesion off. So increasing the femoral head neck offset, so that you don't get impingement in FAI. All right, we're going to talk about hip arthroscopy now. Is anything you wanted to ask about surgical dislocation of the hip, trochanteric flip osteotomies? Don't confuse. So Gans was also he popularized and described a periacetabular osteotomy for DDH, and so that's also a Gans osteotomy. So don't confuse those two. This is a different thing. This doesn't really involve any osteotomies for the femoral or the acetabulum. It's particularly designed to allow femoral head dislocation or hip dislocation and preserve the blood supply. Yeah, okay, hip arthroscopy definitely become very popular from about 2010, probably peaking in popularity. I think my sort of sense is that it probably has peaked. I mean, it is still quite popular. I mean, there's a international arthroscopy society meeting just after the orthopedic congress. Thane Munting, I'm a member of the Hip Arthroscopy Society of South Africa. I don't do a huge number of hip scopes, but I think it is useful in certain situations, and I think the whole community is still trying to figure out exactly what are the best indications for hip arthroscopy. But certainly people are trying, multiple different types of procedures. If any of you are interested in hip arthroscopy, please mail me, or you can say now or before the end of tonight's talk, or get hold of me in the week. There are some hip arthroscopy talks coming up, and I think there is some sponsorship available for the International Hip Arthroscopy Society meeting, and so if you are interested in attending or even being part of giving some of those talks at the Congress, let me know, because Thane he's the chairman of the South African Hip Arthroscopy Society and is looking for interested registrars to help, come and take part and be part of the whole thing. All right, so the classic approach for hip arthroscopy is a sort of inside out approach, where you place a needle into the hip joint whilst under traction, and then introduce some saline or air to try and break the seal of the hip joint and further allow distraction of the femoral head out of the acetabulum. And then over a needle, using a Seldinger type technique, you place various increasing sized probes until you can put the cannula with the hip scope and camera into the hip joint. And then, so much in the same way as you do a shoulder scope or a knee scope, and then using the camera, try and find, your needle or the working portal from looking inside of the joint. This is the main sort of problems and hassles with this is it's a narrow space to get into with the scope. You have to use, when you're inside the hip joint, you have to use a 70-degree scope, which is quite disorientating, and the risk of damage to the labrum is quite high, because you've got a very narrow gap between the labrum and the head to try and pass your needles and cannulas. So it's tricky, and the patient has to be on traction right from the beginning of the procedure, and there's some morbidity associated with the traction that occurs when you do a hip scope. So this Spanish guy, Eric Margolay, introduced a new technique. This is probably back in, I don't know, 2005 or somewhere around there, where you approach the hip joint from the outside first. So the okay, I'll tell you that about a little bit later, just to orientate you to the sort of structures that are amenable to visualization and also procedures in hip scopes. It's basically acetabular labrum, ligamentum teres, and those are kind of the main things that you're going to be able to do from the acetabular side. And then on the femoral side, it's obviously burrs and debridement, burring and debridement of femoral cam lesions. The classic disease process, FAI, or femoroacetabular impingement, occurs when you have impingement of the femoral neck, usually against the acetabulum rim, and this causes damage to the labrum, causes labral tears, is thought to be the cause of the development of labral ossification and osteophyte formation on the acetabular rim, and a precursor to osteoarthritis. So going back to surgical technique of the out-inside approach. This is quite a nice cadaver specimen picture of the space that is utilized, and this is also useful for visualizing surgery for hip surgery done through the direct anterior approach. So you can see the label A over here. I don't know if my mouse is showing up on the screen, but it should be there. Anterior superior iliac spine, and then this E is the tensor fascia lata, and that's going, lateral, and D, the sartorius, going medial. And you can feel usually quite easily on a patient. You can also feel on yourself quite easily if you feel your anterior superior iliac spine, and then if you're sitting, now you flex your hip, so try and lift your knee up off the chair, and then you can feel tensor fascia lata is probably the big, bulky, strong one. They're coming off the anterior superior iliac spine, and then just medial to that, you can feel a little gap where that triangle F is, that sort of triangular V-shaped soft spot, and that is right basically down onto the hip joint. So the only thing there would be a bit of rectus femoris, but if you just push that out the way, you'll be right onto the hip joint. So the closest way to get to the hip joint from the outside of the body is through the anterior approach, through the interval between the tensor fascia lata and the sartorius muscle. The problem is that the lateral femoral cutaneous nerve of the thigh runs just medial to the anterior superior iliac spine A, and it runs in the fascia covering both of these muscles, the TFL and sartorius. So basically straight through this part where you are wanting to approach. So you've got to be quite careful, especially in the direct anterior approach. We make an incision over the muscle fascia covering TFL, so quite far laterally, and then lift that fascia up, and with a finger dissect down to where this arthroscopic probe is there, and then you'll be right down onto some of the fascia covering the rectus femoris, and then just to the lateral of that. So if you push tensor fascia lata away laterally, then you'll see the undersurface of rectus femoris and the hip capsule, basically. So this is just quite a nice anatomical revision of the area that you're going to be of interest. And yeah, it's just a sort of picture of a patient, lying supine with the head on the left and the feet on the right, and just indicating sort of where you would feel for these anatomical structures, and where the portals are placed. As the head is on the right and feet are on the left, obviously the patient's the other way around, just to allow a patient with markings on the skin there for. Okay, and basically the out inside technique is quite easy. You place your working and visualization portals through the skin, blunt dissect down onto the femoral neck, and then with the two instruments almost rubbing basically against each other, you can kind of create a small space in the pericapsular fat on the outside of the capsule, and then using an ordinary 30-degree scope, which is familiar from knees and shoulders, you can look down at your shaver or ablation, diathermy ablation tool, and see the surface, the anterior surface of the capsule, and then make a nice sort of longitudinal incision in line with the iliofemoral ligament, so that you aren't sort of disrupting those fibers transversely. And then obviously when you get up to the edge of the acetabular rim, a kind of T-shaped incision, which will now expose the labrum and the femoral head as it enters into the acetabulum proper. So you can do all of this and expose the entire extracapsular compartment of the femur particularly, without putting the patient onto traction. And then, you've now broken the seal, obviously, of the suction seal of the labrum and of the hip joint, because you've opened this whole thing up, and you can flush arthroscopic fluid, and then much lighter, lower level of traction, you can extract the femoral head from the acetabulum, and then pass. And you can still use a 30-degree scope to look, but it is still much easier once you pass into the intracapsular compartment to use a 70-degree scope to look all around at the different angles. This is just, again, a description of the approach with showing the important iliofemoral ligament and the direction of its fibers. So you kind of doing the capsulotomy in line with the iliofemoral ligament fibers. So then you sort of have a picture like the top left, where you can see the hip being distracted, and then a small gap underneath the labrum that you can then pass a scope in and look into the intracapsular compartment. And then this is just a little bit of sort of pictures to show what it looks like in the inside, what the labrum looks like, what the middle picture showing the probe underneath the labrum and showing this sort of fluffy cartilage flap from the chondrolabral junction, which is the labral tear. And then just how, passing sutures around there. Not too exciting. So just remember the femoral acetabular impingement comprises two main morphological features. One is a pincer type lesion, which is over coverage of the acetabulum that can then impinge against the femoral neck without there being a femoral problem. So there's a normal femoral head neck offset. And then the opposite is the femoral cam lesion, where there doesn't have to be any over coverage of the acetabulum, but because there's reduced femoral head neck offset, the cam, or the narrow offset from the head to the neck, results in early impingement of the femoral neck against the acetabular rim during particularly flexion, adduction, and internal rotation, the fader maneuver. Okay, there's just a picture of the cam. So a cam is, what is a cam? I don't know what a cam is actually. Who knows what a cam is? What is a cam? Anyone? Any car aficionados? Petrol heads? Yes, Yaxel. Okay, AVN. All right, hip scopes. Does anyone want to ask anything about hip scopes?
You asked about the cam.
Yeah, what is it?
Yeah, so isn't it like a part like on cars actually? It's got like a different shape, so it engages sort of with like a, I don't know, it's like a orbital kind of shape as it gets into that point of motion or point of contact. So as it rotates through like an arc. Well,
Yeah,
like exact definition, but that's like my sort of understanding.
Yeah. Look, I was hoping someone might have a sort of proper definition of what a cam is, but yeah, I mean, a cam, you get a cam, you get cams, your cam belt is attached to cams, which are those little oval shaped structures that allow the different opening of the valves in a car. But what is, it's like an oval shape, I mean, I don't know, is there a definition for what a cam shape is? But yeah, I mean, it looks like that drawing on the left.
Yeah, because it helps to change rotational motion into like a reciprocating motion, something to go up and down, like a camshaft.
Yes, yeah. Like a camshaft. Yes. Okay. Well, I like that. That sounds a bit better. Well done, Ahmad. Did you Google that?
No, from a camshaft. That's how it works. So
yeah,
it rotates back and forth for something to go up and down.
Cool. Okay. Good. Well, have a look up your car engine cams if anyone's interested. But basically, that's what it looks like. Something like that. Lateral view of the femur. So you best see a cam lesion with a lateral shoot through of the hip. So if you're wanting to diagnose it on x-rays, you need to ask them to do a lateral shoot through, and ideally try to correct for the femoral neck anteversion. So lateral shoot through with the knee rotated about 10 to 15 degrees internally, so that you can see the profile of the femoral neck, perfectly side on. Otherwise, obviously, you can define it much more accurately using CT or MRI scan. Good. Okay, any other hip scope questions? KT to everyone. The abnormal shape that causes different movements, cam belt, a projection on a rotating part in machinery. Sorry, camshaft. Nice. Who's KT?
Hey, boss. Sorry, it's me.
Well done, KT. Okay.
It's those bumps on a rotating shaft that cause something attached to that projection makes it move up and down while the shaft rotates.
Brilliant. Okay, do you know where that is in the car?
I think it moves. I'm not sure if it moves the pistons, or I know that it just moves part of so those projections move part of the machinery up and down.
Yeah.
Somewhere in the engine. Sorry.
Nice.
I can ask Roger and get back to you on that.
Nice. Ask Roger to enlighten us about camshafts later. Okay, cool.
Cool.
Okay, guys. Last thing, AVN. So we did a core decompression on Monday, so that was quite exciting. Basically, you need to obviously know some AVN classifications, because the classification is very useful for deciding on treatment. Pretty much the practical summary is that we will just kind of use supervised neglect or a watch and see approach for patients with AVN, because we just don't really have the resources to adequately deal with early stage AVN with decompressions or anything else, and so we'll just kind of watch and see, and then do a hip replacement if they have secondary OA that develops later. A lot of early AVNs will take a very long time to collapse and get secondary OA. So if you have an early a small size AVN lesion, it's often extremely painful when it infarcts in the first sort of few weeks, and then it becomes, if it doesn't collapse, it oftentimes becomes bearable or not so sore anymore, and then until the patient will develop secondary OA, and obviously then they get hip pain from that. Having said that, the patient we had on Monday was extremely painful, and she is actually, Kim, I can't remember if you can remember. So when was she diagnosed with AVN? It was actually quite a while ago, number of months, maybe even last year. Hey?
So she had chemotherapy, and she developed the AVN following the chemotherapy. So she's had it quite a while.
Like a long time.
I think her no, not too long. I think she finished she completed her chemotherapy in November 2022. So last year.
Okay, so last year.
But I'm not
so
sure when the AVN developed in the chemo.
Yeah, I can't remember exactly, but it's certainly like a number of many months, But anyway, so it does seem to alleviate pain quite nicely. If the lesion is very large, we haven't really had great success with very large lesions at keeping them from collapsing and causing misshapen femoral heads. which then obviously results in quite quick secondary OA when it's a non-round head, round acetabulum. So what we have done for a few cases at Grooteskier is injectable calcium sulfate, calcium phosphate, biphasic or triphasic, as we were told on Monday, actually, bone graft substitutes or regenerative grafts, injectable graft material. There is some evidence for this. There is a little bit of controversy about which, if it works in all cases of AVN. It seems to be better in alcohol or steroid induced, I think they said, found in this article. But yeah, it is quite expensive, and it comes with quite nice tools to use. Basically do a DHS type position. This is an example of a patient that we did, quite an extensive bone marrow edema throughout the whole femoral neck. She was very painful, actually, and then a kind of a inferior head area of infarct, which maybe is not so risky for femoral head collapse and abnormal shape. So possibly not absolutely necessary to fill this with bone substitute, and maybe just a decompression would have worked. But I mean, she was immediately relieved of pain straight after the operation, basically, just from, I think, probably just from decompressing the lesion or the whole femoral neck. So you can see here the intraoperative fluoroscopy is like a DHS type guide wire that you put in and then ream over it with quite a big sized reamer. So the one concern about that size is leaving it open. So if I was going to do a core decompression and not put any bone graft in, and then I think I would limit it to sort of 4 or 5 millimeter drill holes, 1 or 2 smallish drill holes, whereas this is, I think, a 9 millimeter reamer, so it's quite a big thing. And then this device doesn't show so nicely in this X-ray image or fluoroscopy image, but this device you pass in, and it has a little expansile blade at the tip, which as you rotate, you can, slowly wind out by like 0.5 millimeter at a time, and then it can basically make a big circle inside the femoral head, and you can fill that with this bone graft, which is radio opaque, so you can see it here. And then this is just that patient over the course of 3 months. You can see post-op, nice wad of calcium phosphate sulfate, and then 6 weeks later, a little small sliver, and then 12 weeks later, like a, fully resorbed, and almost looks like there's no bone scar there, which is quite nice. Yeah, as I say, she did very nicely. It is a they're telling us today it's about 16,000 Rand for 10 cc's, which is about as much as that. So that's about 10 cc's that you can see in there. So it's, I mean, it's not that cheap. You can do a hip replacement. The hip replacement prosthesis is probably less than double that. So yeah, you got to sort of think, I guess, whether it's worth it. Right, that's all I have to say about that. Are there any questions on AVN treatments? You probably ought to know about vascularized fibular grafts. So the sort of gold standard for the treatment of early stage AVN with the prevention of collapse used to be vascularized fibula grafts, which are extremely technically demanding. You know, you need to harvest a fibula from the patient with a blood vessel attached to it, and then anastomose that to a blood vessel around the hip, drill a hole in the hip, and then, you know, shove the fibula into the hole like this, you know, bone graft substitute, and then attach the, you know, do microvascular repair. And that used to provide, you know, nearly 100% in certain, you know, hands, certain surgeons' hands, 100% cure of the AVN. But you know, the procedure could take up to 6-7 hours. You know, it's a massively time-consuming thing, and obviously quite a lot of morbidity, having to have your piece of fibula chopped out and all of that. So yeah, you just need to know that was, it used to be sort of thought of as the gold standard, but I think that's gone out of favor. Certainly I've never seen that, or we've never tried something like that. So yeah, so nowadays I think the early AVN would be reserved for cord decompression or expectant treatment. Some people would advise non-weight bearing. I keep these patients that we do cord decompressions, non-weight bearing or touch weight bearing, protected weight bearing, for at least 3 weeks. Probably, you know, it looks like this sort of bone grafts is almost beautifully incorporated at 6 weeks. So I think that they really would be safe from a fracture risk point of view to weight bear after that time. But also just for the treatment of the AVN, if you catch it very early, you know, some authors would advocate keeping the patient non-weight bearing on crutches for a period of 6 to 12 weeks anyway, just to prevent collapse and subchondral fracture and flattening of the femoral head. But also that is also, you know, tricky, and, you know, it's not without its own morbidity, and it's not guaranteed to work. So you know, so your treatment options really for early AVN is non-weight bearing crutches, cord decompression combined usually with non-weight bearing, cord decompression with introduction of bone substitute, regenerative grafts, and then vascularized fibula grafts. Okay, is there any any questions there?
Mark, can I ask something?
Yeah.
All these surgical treatments cure the AVN in that instance, if I can phrase it that way. And then if there's an underlying cause, I mean, off the top of my head, for example, steroid use in a rheumatoid patient or something like that, is it possible that AVN will just reoccur at some later point?
Yeah, that's a good question, Dane. I don't know what they've got. There's quite well-defined dosages and durations of both steroids and alcohol for the occurrence of AVN, but I'm not sure exactly what happens with the ongoing, you know, vascular damage. I certainly don't understand it fully, because, you know, if you have a sort of area of bone that is infarcted from some kind of microvascular pathology, which is what the mechanism is supposed to be, then why does it? I mean, bone is a very, you know, dynamic organ or structure, you know, so why doesn't it just, you know, if you have a little infarct there, I can understand your brain then, you know, dies and you get a scar or whatever, but, you know, why doesn't the bone just, you know, get blood flow from elsewhere? So like the osteocytes can die, and then some, the blood was still flowing around to the other parts of the bone right next door. I mean, wasn't it just start to make little channels to go, to where those dead osteocytes are, and the live ones migrate and move in. So I don't quite understand it, So if you carry on taking steroids, then and it certainly seems to be like a once-off thing, So you have a series. There's only patients who are on like these long courses of steroids, and then they'll have one hip with AVN and the other hip is fine. And so how does that work, And then I don't know. So the answer is I don't know. I don't quite understand it, Dane. So if you core decompress and you kind of revascularize or depressurize some of the venous blood in there or whatever, and then now blood can flow into your area, or you get some bone graft which has got some osteoinductive capabilities, and osteocytes go into your dead area and revascularize it and reconstitute bone there. Now if you take a whole lot of steroids again, does it just happen again? Don't know the answer. So it'll be interesting to, we've got, I think, 3 or 4 of these core decompression with regenerative bone graft patients. It'd be very interesting just to follow them up over time and just see, like, do they, look, I suppose the chemotherapy patient is not gonna, she probably won't have chemo again, so then they won't know. But I mean, a lot of these patients are, I suppose what we need to do is we need to try and find one of the HIV patients, because I mean that would be interesting. I haven't seen, I don't think I can recall seeing an HIV AVN stage 1 or 2. Have any of you guys seen stage 1 or 2 HIV AVNs? Because that would be interesting to try and, because they possibly have got it from the ARV. Well, we think it's from the ARVs, which they're going to be on for life now. So they would just have this continuous sort of vasculitis or vascular insult. So that would be interesting, perhaps, to try and catch an early HIV AVN and try and decompress and bone graft them and see what happens. But I don't know. I suspect it's, sorry, Dane. I'm waffling on. I don't know the answer. It is my full take is, I'll go back to the practical summary at the start of this, is that, it strikes me a lot to be a bit of a waste of time, this thing. I think we see patients that they seem a lot better. So our experience is quite small in number, and they all seem very happy and better. So, maybe I'll change my mind after we've done, many more. But my sense is that it's just, it's, perhaps in selected patients that have had once-off, perhaps the HIV patient is not the good patient to do. Maybe these ones, a single course of chemotherapy that causes it, but they're not going to have that any more chemotherapy. Maybe those are the patients that we need to try and do and get better, because then won't develop it again in the future.
I just had one, and then just one other thing. And the role of using any adjuvants. I know this thing about core decompression with BMPs, like injecting that into the head. I don't know if that's.
I haven't heard of that, Ahmad. What do they? Where do they get the BMPs from?
So it's the one they've been using, that they use on open fractures or on non-unions. The same.
Okay. Yeah. Is it like a putty? Is it a commercial substance?
Yeah, commercially available.
Yeah. I don't know, because I have also, I've read or heard about, autologous, like PRPs, purified platelet or plasma. What's it? Plasma derived platelets, or what do the PRP stand for again? I've heard of some people trying PRP injections. But I don't know. Not sure about that. I haven't read too much about that. But I'd imagine like BMPs, you know, that sort of makes sense to me. There's also talk of the bisphosphonates, you know, but I think that's also, I don't know, you the exam guys, have you read about bisphosphonates in AVN? What's the latest on that?
No, I don't know.
Yeah, I think the last I seem to vaguely recall was that it does seem to be very helpful for the acute bone pain from avascular lesions. So the natural history of the avascular necrosis pain is one of resolution. So it seems to be very painful in the very early stages, like, you know, weeks basically, where the infarct is happening, and then that acute pain usually subsides. Now it's not the case in our patient from Monday. You know, the acute pain, well, it had, I think it was probably less than it was right in the beginning, but she was still very sore. But usually, you know, we've had a number of patients who will come to us and we'll kind of be considering core decompression, and then they, you know, we see them, we can only book them in, you know, a month or 2 months time or whatever, and they come for pre-op, and they actually, you know, they're much better. You know, the pain is a lot less. They're kind of moving okay. There's no sign of collapse. So we say, oh, well, let's wait and see, and then they kind of trundle on. Bisphosphonates, I think, help in that very acute phase quite a lot with pain, but I'm not sure. I can't remember the mechanism. I don't think was a well-defined mechanism. Okay, cool. Anything else, guys?